on behalf of West Bengal Academy of Pediatrics. Today we have our seventh session of Listen to the Legends. Today's speaker is Dr. Anoop Verma. He needs no introduction. He is the maestro in the field of pediatric neurology. And his topic today is the decoding epilepsy, mechanism, mutation, medication, and the misfires. So he will for 1 hour he will deliver his talk. We are very happy that our mentor, Professor Apurva Ghosh, is there. So, sir, if you just give a word of blessing. Hello.
Sir is
Apurva sir,
muted.
sir,
Okay.
you are muted. Can you?
Apurva, you are muted.
Sir, he can unmute. Yes, he has the permission, sir.
So, you, unmute him.
Sir, he can unmute, sir. He's
So,
unmuted, sir.
Apurva,
We are sending him
so
request, sir, to unmute.
Apurva, please.
Yeah. My my best wishes for you all always there. And I know Anoop for a long time. I know Anoop for a long time, and he's a very good friend of mine. And I read his rare cases every day. Every day, whatever he posts, I read every day. Let's start now.
Okay. So,
Thank you,
over
sir.
to you, Mihir.
Yes. Thank you, sir, for your blessings. And again, another Saturday evening, whenever the West Bengal Academy of Pediatrics invite you all and welcome you all for this listen to the legend. So today we have none other than Professor Dr. Anoop Kumar Verma. Like Saptoshika, he has a numerous fan all over the country, and everyone knows of him. So, and this moderating this session, we have Professor Kalpana Datto, Madam, my HOD of Medical College Kolkata, and my head of the department. And Madam is a very popular teacher, and all the pediatric neurology in West Bengal has been grown up with the by Madam has handholded, and from the beginning of this chapter to the at the present state where the new generation is taking the baton and moving it forward. And also we have Professor Sukhanto Chatterjee sir, who is my teacher, my mentor in the Medical College Kolkata. And was I will hand over with this with the Professor Kalpana Datto madam to introduce our speaker sir, Dr. Anoop Kumar Verma, and start the session.
That I will say that our senior Dr. Sukhanto Chatterjee is there. So with his blessing and Atanu has also joined. So we can invite just for a word of blessings from both of them.
Let Atanu.
Sukhanto sir, please.
Okay. So, good evening to all. And I am very honored to have today's speaker, Dr. Anoop Verma, with whom I have a long relation. And I am really happy to listen to you, Dr. Anoop. And thank you, West Bengal Academy of Pediatrics, for organizing this beautiful scientific program that is organized every month. And I am also happy for the entire team of West Bengal for taking this scientific fish forward. With these few words, I finish here and thank you once again, West Bengal Academy of Pediatrics, and particularly today's speaker, Anoop Verma, and moderator, Dr. Kalpana Datto. In spite of her illness, she has joined to make this program success. Thank you.
To Sukhantada, Dr. Atanu Bhadro, the Central IP Treasurer, is here. He is very busy. He is in the meeting. So, Atanu, can you just please say one line to welcome all? Atanu.
One line is not sufficient for Dr. Anoop sir, because a person who is totally dedicated for the last 2 decades, I am seeing him totally dedicated to academics all across the country, traveling all across the country, sharing his knowledge, because I think there are many knowledgeable people in IIP, but Dr. Anoop sir is one of the persons who doesn't hesitate to share it. Even now, every month, every week we look forward to his potters, and it is really we have a real fan following person, so we are really glad to have him today in this program. Please, continue the program. I'll be.
Thank you. So now
Thank you.
it's Dr. Kalpana Datta.
Yes. Okay.
So,
Very good evening to all of you. And thanks to West Bengal Academy of Pediatrics for giving me this opportunity to moderate this important session with such a august speaker. I'm really feel honored to moderate Sir Dr. Anoop sir and with the respected senior persons, Dr. Apurva Ghosh, Dr. Sukanta Chatterjee and all others. Today we have the listen to legend, and he's the really legendary body, Dr. Anoop Kumar Verma. He is the doyen of pediatric neurology. And in West Bengal, pediatric neurology has started with this his hand only. So we started in 2014 with the Dr. Anoop Verma. And he is having many awards in his name. And he's attached to the Swapnanil Nursing Home, Raipur, Chhattisgarh. He has been awarded Doctor of the Year, National IME by 2015, FIAP, FIMS, FCGP, Honorary Fellow of Academy of Pediatric Neurology. He has delivered many famous orations. I am not going to read all the orations because he has many orations has delivered, and he has publications in his name, and he's the editor in chief in the PI Textbook of Pediatrics, IP Textbook of Pediatric Neurology, Spotters. Today, I think it is the 108th spotter we have received. So we are waiting. I don't know where it will end. How many will be there? So, and he is a national ABM. So he is having lots of positions in the IP, a national vice president in IP 2005, national chairperson of Academy of Pediatric Neurology, CWC member, CJ state president in Chhattisgarh, and IP Constitution Committee member. Now he is also in the Pediatric Neurology Fellowship Program also, and Central Zone Coordinator in the Early Childhood Development by 2022 to 2023. I'm not going to read any more. Many more things are there in his name. So to short, it is sufficient to introduce because he has many awards and lectures, orations in his name. So I welcome you, sir, for this epilepsy, which is a very common topic. We do get every OPD one or more cases, and there are lots of over treatment, under treatment, and the confusion is still there. And until unless you know the mutations, the mechanism of action, you cannot choose the drug. So today, let's demystify all the problems with the Dr. Barama sir. Sir, please.
Thank you. Thank you so much, Dr. Kalpana, for the nice introduction. And let me say that I belongs to a group of general pediatrician working with interest in pediatric neurology and clinical genetics right from the beginning. Respected chairpersons, esteemed dignitaries, and dear friends, it is truly a privilege and an honor to be a part of this distinguished academic forum. Listen to the legend, an initiative that is so perfectly blends the experience, wisdom, and the pursuit of excellence in the pediatrics. At the outset, I wish to extend my heartfelt gratitude to our dynamic moderator, Dr. Kalpana Datta, a stalwart of AOPN and a national force in evidence-based pediatrics. Her commitment to fostering academic excellence has been a beacon for many of us across the country. I am equally grateful to ever inspiring Dr. Atanu Bhadra, our national treasurer, whose visionary leadership continues to shape the national pediatric landscape. His presence today enriched this gathering immensely. I salute to the leadership of West Bengal Academy of Pediatrics, Dr. Sopanji, a name who is the president, sitting president, a name synonymous with the academic integrity. Dr. Kripasindhu Chatterjee also is a now president-elect with a strong academic vision. Dr. Ashok Datta, whose tenure was also very good. Kudos to Dr. Mihir Sarkar, Dr. Vinay Sawa, Dr. Indu Surana. They all, Dr. Amita as a joint secretary, and definitely Dr. Sukandar Chatterjee, Dr. Divyandu Chaudhary, who represent a formidable executive board from West Bengal. Their collective energy has elevated West Bengal Academy of Pediatrics to one of the most vibrant and visionary state branches of the Indian Academy of Pediatrics. Special appreciation goes to Dr. Subhashis Bhattacharya, who is the scientific chairman whose academic foresight is already visible. I must also acknowledge the presence of respected academician and clinician from the West Bengal uh, West Bengal from Dr. Arijit, Dr. Apurva Ghosh sir, Dr. Saptashika Ghosh, Dr. Sudeep, Dr. Jasodhara, and many others whose silent dedication speaks volumes in shaping the pediatric health in this region. West Bengal Pediatric Academy has always stood tall, not only in academics, but in every spheres of organizational excellence. And with the National Pedicon 2026 poised to be hosted here in January next year, the spotlight is firmly on this dynamic team. I have no doubt it will be a landmark event setting new standards for academic engagements. As I move forward with my presentation, I do so with deep respect and admiration for this extraordinary platform and the visionary who nurture it. Let this be not just a session of knowledge sharing, but a celebration of commitment, celebration of continuity and collaboration. Thank you once again for this gracious opportunity. My deep sense of gratitude toward West Bengal Academy of Pediatrics, where intellect meet integrity and tradition fuels the transformation. Team West Bengal does not just host the event, it sets the benchmark. So this was just an introduction, and thank you so much for my core of the heart. And let me now share my screen for the presentation. Is it visible, sir?
Yes, sir. Yes, sir. Visible.
It is visible. Okay,
Audible and
okay,
visible,
okay.
clearly.
So the topic of today's discussion is decoding. As a pediatrician, we often get such type of patient day in and day out in our in our OPD, and definitely we guide according to the present knowledge and present recommendation by the ILE and by the OPN as well. Now, I have chosen the aim of my talk is the concept of decoding epilepsy in different way. This talk is definitely a different sort of in the way that we will talk on the mechanism. That would mean the role of ion channels in epilepsy. Mutation, that would mean that the roles of genes in epilepsies. Then we will go to medication choices and role of anti-seizure medication in say, different indications. Then misfires, that would mean the adverse effect, which is not expected out of the treatment. So now we all know that this generation of the action potential is one of the very important area. The knowledge of the physiology is still important, and you are seeing the voltage gated sodium channel is on, and the yellow waves you are seeing is crossing is the generation of the action potential, and you can all recollect that depolarization wave is just sodium enters into the cell, and repolarization, the potassium comes out of the cell, and there is the creation of the action potential which is transmitted from the neurons to neurons. And let us see what is the you are seeing here. Seizures, we all know that the seizure occurs when a small group of abnormal neurons undergo prolonged depolarization. And this, we have seen that how depolarization is associated with the rapid firing of the repeated action potentials. Hypersynchrony and hyperexcitability are the two important properties of abnormal neurons. That hypersynchrony means refer to a population of the neuron firing at the same time at a similar rate, and hyperexcitability refers to the concept of seizure threshold. A certain level of the excitability must be exceeded for the seizure to be generated. So it is a low threshold creates a sort of hyperexcitability in the neurons. And we all know the epileptogenesis could be so many reasons, like genes, abnormal membrane channels, intracellular signaling cascade, abnormality in the neurotransmission, synaptic connectivity, and to induce all this, there is a permanent state of either hyperexcitability or hyperchronicity. We all know that there are the GABA is the neuro inhibitory, and this is the glutamate axis causes excitation. And so there is if there is a disturbance in the balance between the inhibitory and excitatory is responsible for generation of abnormal seizure activity. Now, coming to the ions, see, this is always remember that the conduction is the action potential. You are seeing the voltage gated sodium plant. Now, this is the as soon as the stimulus or hyperexcitability or hyperchronicity comes, you can see that this wave of depolarization comes to the end of the terminal, and you are seeing that this is the voltage gated sodium channel, and this is there is the influx of the sodium in the cell, and you can see that. And as soon as there is the wave of depolarization, this calcium channel also becomes active, and lot of calcium is there is an influx of the calcium channel. As a result of inside calcium excess, this is the synaptic vesicle, which is containing full of loaded with the glutamine, and this is known as the SV2A, synaptic vesicle 2A. This is now liberated. This excess of potassium causes release of glutamine into the synaptic cleft. And as soon as the glutamine is liberated here, there are two glutamine sensitive receptors. You have to see there is a AMPA receptor and NMDA receptor. It is AMPA receptor is responsible for conduction of sodium ion inside the post terminal, and NMDA responsible for conduction of the calcium ion. And similarly, this rush of the depolarization goes into post-terminal causing the seizure, as you are seeing the child. Now, this is not always happen. There is inhibitory also there. Inhibitory function is also there by GABA terminals. Now, what you are seeing is a lot of GABA is released as in response to a lot of glutamate. This GABA, which is a neuroinhibitory, there is a GABA receptors in this chloride channel. This is the chloride channel. There are GABA receptor. This, as soon as the GABA is attached to the chloride channel, immediately lot of chloride ions are transmitted into the, and this keeps the balance and checks the, it has an inhibitory effect. So a lot of GABA, which is now released in the synaptic cleft, is now taken back by GAT1, that is the GABA transporter, into this again cell, and here GABA is degraded by GABA. This mechanism, why I am discussing is that because at each channels, and this is calcium channel, sodium channel, potassium channel, and this they all the anti-epileptic drug has a different mode of action. They are all responsible for block
I think he
Sir,
has
please
lost
unmute.
his.
Anoop sir, please unmute.
Am I audible?
Yes, sir. I guess your network got this. Can you
Oh.
please reshare?
Acha, yes. Am I audible, sir?
Yeah, you are audible.
Sir, please share
Please
your
Your
screen.
slides are not visible.
Sir, share your screen, please.
It is not coming.
Yes, sir. Full screen, please.
Just a minute. Is it okay, sir?
Yes, sir. Please continue.
Is it okay?
Yeah.
Sorry, I don't know what happened. I don't know. Okay.
Net.
So this is how. Wait, just and now this slide depicts that what are the drugs. You are seeing the in red block. These are the drugs which act on the sodium channel, and these are the drugs like valparin, lamotrigine, topiramate. This is acting on the calcium channel. Now we know that lot of glutamate, that is the anti-glutamate drugs, are valparin, felbamate, and lamotrigine. And again, you can see the to enhance the GABA, that is the GABAergic drug, that is the inhibitory drugs, are the benzodiazepine and the phenobarbital. We have levetiracetam and brevitiracetam acting on the SV2 vesicle and checking the release of the glutamate into the synaptic cleft. Your potassium channel is blocked by felbamate, and this is again important T type of low voltage calcium channel, which is responsible for absence epilepsy. And you can see valparin and ethosuximide are blocking this channel to have a therapeutic effect. You can also see the vigabatrin is a GABA T inhibitor. So these are the tiagabin GABA transporter, inhibiting the GABA transporter. So these are the how the anti-epileptic drug has its effect, the mechanism. Again, there is again a concept that how generalized tonic-clonic seizures are produced. You can see that is the spontaneous firing of this is the thalamus. There is a T type of calcium channel in the thalamus is there, and this abnormal low threshold discharges are produced in the thalamus, and it is through the thalamocortical tract it reaches the cortex, and thereby it is depolarizing the cells of the cortex, and as a result, by means of corticospinal tract, this is due to the opening of the sodium channels. And this sodium channel all throughout the corticospinal tract opens the sodium channel, and in the spinal cord and the muscle there is opening of the sodium channel, and causing the tonic-clonic seizure, as you are seeing here in this. You can see this GTCS is why, because due to the opening of the this is the T type of calcium channel and the sodium channel. So to treat GTCS, you have to block calcium channel and the sodium channel. So in this genesis of the absence seizure, what is happening is the action potential generated in the thalamus by the low threshold T type of calcium channel never reaches the cortex. As in the GTCS, it reaches the cortex, but in absence seizure, it never reaches the cortex. It circulates in the thalamus only, and action potential continue to circulate in the subcortical area at never involves, and this is responsible for the 3 spikes and waves as we see in the. So in a generation of absence seizure, it is the calcium channel only, and therefore to treat absence seizure, we have to block calcium channel by valproate or by ethosuximide. Now, what about focal seizure? Focal seizure could be due to granuloma, could be due to gliosis and tumor, and lesion is always in the cortex. And it is an irritating focus, and there is action potential is generated by opening of the sodium channel, and through the corticospinal tract reaches the spinal cord, opens the sodium channel there, transmitted to the muscles, opening the all throughout the sodium channel. So to treat focal seizure, you have to block the sodium channel, for example, carbamazepine and other sodium channel blocker drugs. So these are the basic concepts. Now, after having we will go to another section, that is the mutation. We have seen the mechanism. We are coming to the mutation, and we all know that all the channels we have just seen, sodium, potassium, calcium, GABA receptor we have seen, we have NMDA receptor, we have seen AMPA receptors, and these are the genes which are controlling these channels. So the mutation of, for example, mutation of sodium channel, that is the SCNA1 mutation, we are going to give the JEFs, and we will see one by one each. And now, this is the voltage gated sodium channel. Now you are seeing here the you can see the mutation in the sodium channel, that is the SCA1A, SCN1A1A is responsible for JEFs, the Dravet syndrome, epileptic encephalopathy. So these are the importance of knowing the channels and the gene controlling that. Here is the Dravet syndrome. You can see this is the mutation in the sodium channel giving rise to SCNA1A, and these are the other area where the GABAR1A and GABAR-D producing idiopathic epilepsy as well. Now, coming to the spectrum of SCN1 syndrome, we know that 70 to 80% have mutation in SCN1 gene. Mostly they are sporadic with haploinsufficiency, and this SCNA mutation consists of many syndromes. From mild, like febrile seizures, to extreme right is the Dravet syndrome. And there is an abnormal sodium channel in all the situations here. So it is very important to note that if seizure worsens with sodium channel blocking drugs, think of SCNA1A. This is again because we know that sodium channel blockers like phenytoin, carbamazepine may exacerbate seizure in SCNA1 related disorder. So any patient with febrile seizure or a febrile seizure with not responding or the seizures are aggravated, so think of especially after sodium channel blocker drugs. So this is the spectrum. One side, it is a familial hemiplegic migraine to Dravet syndrome. This is the febrile seizure plus and JEFs and all. So we have to remember the 5 criteria: normal or near normal cognitive, and if a child is having 2 or more seizure with or without fever before 1 year of age. Seizure may be monoclonic, it can be hemiclonic or GTCS. 2 or more seizures should be more than 10 minutes. That is, the 2 status should be there. Failure to respond with the first line anti-epileptic drug with continued seizure after 2 years of age. So out of these 5 criteria, if 4 is there, you can label a patient to be having a SCNA1 disorder, and you can go for gene analysis or mutation analysis. No two SCNA children walk the same path. This is again very important. And clinical heterogeneity is the hallmark. Even within the same mutation, phenotype vary from JEFs to Dravet syndrome. So that has to be, this is the clinical markers of certain conditions. Now coming to the potassium channel. We have seen sodium channel, the SCA1 spectrum, now the potassium channel. Now you can see the mutation in the KCN2 is responsible for benign neonatal infantile spasm, epileptic encephalopathy. KC4.1 is responsible for migratory malignant partial seizure of infancy or autosomal dominant nocturnal frontal lobe epilepsy. These are the genes which are responsible for this type of epilepsy. This is the benign familial neonatal seizure. You can see this is the basically this mutation is responsible for such type of seizures. Now coming to the calcium channel, you can see the genes which is responsible for controlling of the voltage gated calcium channel is CACNAH1. It is responsible for IG, idiopathic generalized epilepsy, like that. Here the GABA A receptor and NMDA receptor channels, and you can see the GABA A receptor, which is in the chloride channel we have just seen, is controlled by all these genes, and mutation in these genes is responsible for this. Similarly, NMDA receptors, which is under the control of these genes, if it is mutated, is going to cause these type of conditions. So we can see that genetic association of epileptic encephalopathy, these are the genes like Otahara, EME, West syndrome, SME, and these are the genes which can have this effect on patient. And therefore, we have to remember the symptoms and how to treat this condition. And this we are coming to the third area of our presentation is the medication. We have seen mechanism, we have seen mutation. Now coming to the medication, and you can see that just I have kept this slide to show you that these are the sodium channel blockers. These are the GABA agonists. These are the GABA receptors, NMDA receptor. This is the GLUT-R, and this is the calcium receptor. Just to show that these are the drugs which affects this. Now coming to a very important and a very updated ILE evidence. This is a literature for the efficacy of anti-epileptic drug as an initial monotherapy for epileptic seizure and these syndromes. This is the busy side. We will discuss in now. A patient is there who is exhibiting a generalized tonic-clonic seizure. And we know that in GTCS, high voltage calcium channel are abnormally behaving, and sodium channels are also abnormally behaving. And so we have to block both the channels. So we have to use calcium sodium channel blockers and the calcium channel blockers in this. And if we correlate this study which we have just seen, you can see according to that study, no drug qualifies for the level A, that is the established efficacy for GTCS monotherapy. No drug qualifies for the level B, that is the probably efficacious. All the drugs like carbamazepine, phenytoin, and these are the drugs that are possibly efficacious. So we have to remember that these are the no drug qualifies for A and B for monotherapy. This is the you can see the partial seizure, and we know that it is all throughout is the sodium channel and sodium channel blocker drugs. So what is there in this literature? Oxcarbamazepine, we all know we use oxcarbamazepine in focal seizure, but this is the right evidence that it has established efficacy. That is the level A evidence is there for oxcarbamazepine in focal seizure, and no drug qualifies for the B, and possibly efficacious all these drugs, and potentially efficacious all these drugs. Coming to the absence seizure, this is again very important. You can see that we know that it is the low voltage T type of calcium channel which is abnormally behaving, and we have to block that. And you can see that the established efficacy is the valproate and ethosuximide. These are the drugs which directly act on the low threshold calcium channel and blocks these drugs. Therefore, no drug qualifies for B. Lamotrigine qualifies as a possible efficacy. We do use lamotrigine also in absence seizure, but we should know that it has a level C, that is it has a possible efficacious. So we have to remember that T type of tremors find calm in ethosuximide. That means that the T type of abnormally behaving neurons can be calmed by ethosuximide, and the references and it's all there here. Now, this is the patient of CELECT. That is the previously it was known as the BECT. It is the self-limiting epilepsy with the centrotemporal spikes. And you can see that no drug qualifies for controlling the CELECT seizure, established none. Possibly if it's a carbamazepine and valproate like that. But it is very, very important that we should remember, or we know that Not all seizure need a script. Sometimes reassuring is the best prescription, and this is true for select. Coming to the, again, a very difficult epilepsy to control is the juvenile myoclonus epilepsy. We know that it has a myoclonic component, it has absence component. We know that it is having a GTCS component. You can see that no drug qualifies for the level A, B, and C. Only we have potentially efficacious like topiramate and valparin. So this is a very difficult epilepsy to control. Treatment may be lifelong. In GME, broad spectrum is the rule. Narrow drugs may fuel the fire. This is again a message. Now, this is the approach how we can go with ILE recommendation. Any patient who is convulsing or who had a convulsion, and you are going to examine and treat this patient, always have a detailed clinical history. Age at onset, we all know. Seizure semiology, duration, frequency, triggers, definitely developmental milestone has to be taken care of. Family history of epilepsy is again very important. Family tree should be drawn. Perinatal and past medical history is again very important. And so it is, history is the headlamp. It shows the seizures path and its past. This is very, very important. Now, physical and the neurological examination is very, very important. Look for the focal deficit, neurocutaneous markers. We often forget to examine the patient in detail, and possibly you may miss a asleep appear or a adenomastivation can be missed like that. So developmental or behavioral abnormality is important, and body may whisper what the brain tries to hide. This is again important. Body is whispering to see you that yes, I am here and I am giving you the clue. So we may miss the neurocutaneous marker, and other positive neurological signs should not be because body is showing, body is trying to give you information. Now, EEG, standard EEG with activation, we know all that hyperventilation and sleep deprivation is good. Sleep EEG again, but the video EEG is the gold standard. And it is a very, very important thing that EEG supports the story, but never tells it alone. EEG should be interpreted in clinical correlation. This is again important. Don't go with EEG alone. Try to correlate clinically. Neuroimaging. Why neuroimaging? Epilepsy protocol is must when it is a focal epilepsy, or if a child is having a seizure with developmental delay, if the seizures are not under control, or you are suspecting some structural lesion if it is a focal sort of one. Or so avoid CT unless it is an emergency. MRI is always a number one. So to treat the fire, find the spark. MRI looks beneath the bark. This is again an important message. Genetic testing. Always consider when early epilepsy is there, especially it is not under control less than 2 years of age. Drug-resistant epilepsy is there. There is a developmental delay with epilepsy. Syndromic part is there. So use the gene panel, whole exome sequencing or single gene test depending on the phenotype. This is again when the pattern is puzzling. When the pattern is puzzling, the gene may be the puzzle piece. This is again a very important message. Now, metabolic workup. When you will do metabolic workup in a case of epilepsy, if it is a neonatal or infantile onset epilepsy, if it is a refractory or clustering seizures are there, if you are thinking that there are many systems are involved, if there is a regression or episodic encephalopathy there. So test for ammonia, lactate, biotinidase, TMS, organic acid like that. So when the seizures are stubborn and strange, think of metabolism's range. This is again a message that you have to do metabolic workup in all this situation. Now, infections or autoimmune screening. When you will do autoimmune, new onset focal seizure with encephalopathy is there, rapid regression is there, or suspected autoimmune encephalopathy is there, or post-infectious or refractory seizures are there. So when seizures are sudden and the mind is lost, think virus or immune at any cost. This is again important. So principles of drug therapy, we have just important principle. Attempt monotherapy always. Start monotherapy always. Start with low dose. What is recommended is start with low dose and increase gradually. Always escalate gradually. Ensure compliance. It is a very, very important area that whenever a patient you are treating, compliance has to be checked in every visit. In recurrence, increase the dose to maximum pharmacological dose or maximum tolerated dose before thinking to add something else. So seizure relating, that is the selection of the anti-seizure medication. When what are the criteria? If the patient is having a generalized seizure, you will have a different sort of consideration, and if it is a focal one, you have to. If the child is in an infant or is an adolescent girl, if the drugs related consider like the side effect profile is again a very important consideration. Cost is also important. As for example, a neuroepileptic drug, they are very good in the side effect profile, but they are costly also. Mechanism of action is also important. Comorbidities, if what are the drugs which is having a renal excretion, then what are the drugs which are having a hepatic excretion, that has to be taken care of. Now, this is a slide just to show you, according to that paper, I have just made like seizure or syndrome. If the child is having focal seizure like this, child is exhibiting focal seizure, oxcarbamazepine is the drug of choice. And if the having a patient is having generalized seizure, and if the child is less than 1 year of age, you can see phenobarbital, levetiracetam can be useful in this. If he is a adolescent girl, levetiracetam or bevitiracetam or topiramate can be used, and in for rest we can have a valparin. Now coming to the epilepsy syndromes, you can see if the epileptic spasm is there. We know that epileptic spasm may be with tuberculosis, with tuberous sclerosis, or without tuberous sclerosis. In non-tuberous sclerosis, we all know that we are using ACTH. With tuberous sclerosis, everybody knows now vagobatrin is used. For pure abscences, we all know that ethosuximide is the drug of choice, and when absence and GTC is there, valparin. Now JME, if JME is in girl, levetiracetam or topiramate is the drug of choice, and in boys you have a valparin. For Jeff's valparin, and for Rolandic with frequent generalized seizure, we know that Rolandic does not need much treatment, but if it is a frequent generalized seizure, clobazam, levetiracetam, brevitiracetam maybe can be selected, or no or without general seizure, oxcarbamazepine can be there. Now, this is, we have completed the mechanism, we have completed the mutation, we have completed the management, that is the anti-epileptic drug. Now we are coming to another very important area for clinician is the misfires. Misfire is, we have not expected that result. This is actually the, sometimes we learn more from the man's error than from his virtues. This is a age-old proverb, very relevant for this misfires. And you can see, we all know that the concept that every drug which we take has to pass through the cytochrome P450 system, which is embedded in our body, in liver, in intestine, lungs, kidney, plasma. They degrade the drugs. This system degrades the drug. And what is plasma half-life? Plasma half-life is generally the time to decline the plasma concentration of the drug 50% from the peak plasma concentration. This is the half-life that is known as. And similarly, if there is a decline, if you have started declining the dose, if you have stopped, then suddenly the system will contain the drug. Unless it is 6.25% will usually be below the threshold. Means when the drug level reaches the 6.25%, then it will have no response. So this is important, clinically important when you have started declining the dose or stopping the drug. For this reason, it is usually said the drug no longer have pharmacological effect for life after the last dose. You have stopped today, it will not last only today. It will persist for 4 half life. So you should remember for important drugs. Now, this is again a very important chart that we want that whenever we treat the patient, we want that the drug should be in the this range. That is the very important. That is the steady state. Steady state is responsible for therapeutic response, and to reach the therapeutic stage, every drug has to be escalated in this system, and it is said that every drug needs 5 half-life to reach the steady level. That would mean if you have started drug today, it will take 5 half-life of that particular drug to have effect. So that is very, very important, and you have to counsel the patient. You are starting drug today. It will take 2 to 3 days, or according to the drug which you have prescribed, that the effect will reach after 2 to 3 days. So this is the therapeutic range, and after this therapeutic range, we have a toxic effect can be seen. And you can also see by this chart that controlled release preparation have a steady plasma level. And the plain preparation, if you are using plain preparation, then it has an erratic response. And a steady plasma level is only achieved when you are reaching the controlled preparations. See, these are all basics of the not only for epileptic drug and any drug. And I thought to include this area because nobody touches this area for this metabolism and half-life and all. And this is the pharmacologic. Any drug, for example, we are seeing the anti-epileptic drug degraded in the liver, and there's a reactive metabolite is formed, and most of them is the liver is the usually the first casualty if it is a toxic one. Then a first mutagenic carcinogenic can be formed if it reacts, if the metabolite reacts with the DNA. If the metabolite reacts with the protein, we have a target organ damage. Idiosyncratic effect can be there. And if this reaction with the protein produces immune hypersensitivity. This is again a very important, very dreaded, a very troublesome Steven Johnson syndrome. And these are the black box warning. You can see all the first generation anti-epileptic like phenytoin have a Steven Johnson syndrome. This is the, you can understand that there are 26 FDA approved anti-seizure medication, and out of which 38% will have black box warning. So before prescribing, you should also relate the black box warning. For example, if you are using carbamazepine, it is having a very severe dermatological reaction, especially for HLA-B 1502, anemia, granulocytosis, valparin, hepatotoxicity. We all know that it is a lamotrigine for Steven Johnson skin reaction, vigabatrin for vision loss. These are the black box warning. It should be always at least one or two warning should always be remembered. Now, there are certain conditions when you give the drug and there is a worsening of the seizure. So, what could be these conditions? Now, you are seeing here, for example, this is the absence seizure. You have to avoid carbamazepine because it is a sodium channel blocker. He has a atonic seizure. We don't give sodium channel drugs in myoclonic seizure as well in JME. This is the paradoxical worsening of the, you can see the seizure, for example, vigabatrin and phenytoin if it is given. Now, paradoxical worsening of the seizure may be seen in myoclonic seizure. Avoid carbamazepine, lamotrigine, gabapentin, myoclonic seizure. Paradoxical worsening of the seizure is also in tonic seizure as well. So, avoid IV benzodiazepine in these conditions. Now, these are the few cases I will show you. My cases are there. After giving anti-epileptic or starting anti-epileptic, if the patient shows such type of rashes, so maculopapular rashes are quite common. It can be due to this the phenytoin, carbamazepine, and anti-epileptic drug, and these are the other drugs. And phenobarbital is also relate to the macular drug rashes is there. You can see the fixed drug eruption is again a very important area where phenytoin, carbamazepine are the sole culprit. You can see the bullous drug rash and carbamazepine and phenytoin are very important. Now you can see this patient. This is the phenytoin-induced gum enlargement. You can see this is the my patient, which was he received phenytoin, and you can see currently there are more than 20 prescription medicines which are responsible for gingival enlargement. This is very important. Now, a patient 3-year-old, he's in front of you, received some anti-epileptic drug. They presented with, see the fever and such type of rash. So we should all remember that involvement of two mucous membrane is an indicative that something serious is going to happen, and maybe a Stephen Johnson syndrome. I've just kept that these are the two mucous membrane which are involved, and is it indicative of it may herald the onset of severe skin reaction. And you can see the explosive onset, and it took weeks to recover in this patient. So phenytoin, valparin, phenobarbital, lamotrigine, carbamazepine are the sole culprit for this. And you can see you can have a rule of 9, and as correlate as in burns, you have to for treatment purposes. Another patient of mine, and he received carbamazepine and had very severe Stephen Johnson syndrome, and lost her eyes. And but we must remember, for practical purposes, usually the Stephen Johnson syndrome usually develops in the first 3 months of therapy. If you have started today and some rashes occurred after 4 months or 5 months, so it will not be, you will be on the safer side, because usually in 99% or several reports are there, it usually occurs in the first 3 months of, preferably 7 days to 21 days, but it can be in the first 3 months. The inheritance of HLA allele follows the Mendelian law. That has to be remembered. And we all know that this is the basic mechanism of how this dreaded skin reaction is there. We know that these are the ingested drug, reaches the cytochrome P. We have just seen what is the role of cytochrome P. And there is a liberation of the metabolite, that is the toxic metabolite, arene oxide. And this arene oxide is in the suspected individual is acted upon by the epoxide hydroxylase enzyme, and it degrades. But there are certain situations where there is no epoxide hydroxylase. So this arene oxide reacts with the binds with the keratinocyte RNA, and there is the epidermal necrosis. So this is basically the arene oxide which is responsible for Stephen Johnson syndrome. What happens? So all the anti-aromatic, anti-epileptic drug like phenytoin, carbamazepine, phenobarbital, they all cross-react. If he has reacted with carbamazepine, don't give phenytoin in this patient or oxcarbamazepine. They will also have a similar sort of reaction with these drugs. So as this literature shows that 40 to 80% there is a cross reactivity. So what intermittent benzodiazepine can help building the level of the levetiracetam or topiramate. These are the drugs, and HLA B1502 is very important nowadays. And nowadays there is a screening of HLA B1502 in many centers in India, especially if you have chosen to prescribe carbamazepine in this patient. There are reports of phenytoin also having HLA B1502, oxcarbamazepine also 1518 also. Lamotrigine also produces severe, but there is HLA B3802 and HLA A2402 is also responsible. So this is a sort of HLA B1502 screening in a lot many center before prescribing the carbamazepine. You can see that this is the whole, it is a very simple sort of algorithm is there. If you find that HLA-B1502 is positive, try to avoid or not to give, and write in prescription that this patient not to give the sodium channel blocker or this carbamazepine to avoid such type of data rejection. This patient had a focus seizure, was given oxcarbamazepine, reacted. You can see though the rashes to mucous membrane and skin reaction less than 10% was there, and when it was seen that search of report, the HLA-B1518 oxcarbamazepine induced Stevens Johnson syndrome can also edit or cross-react with carbamazepine as well. This is also obvious that after just starting the anti-epileptic drug, child is having ataxia, and we know that benzodiazepine, clobazam, nitrazepam, and these are the drugs, phenytoin, amitriptyline, and oxcarbazepine can have ataxia. So that has to be taken care of. This is again a patient who of infantile spasm was given valparin, very rare case. And now you are seeing the paroxysmal tonic upgaze, that is the oculomotor syndrome. You can see the PTU, tonic upgaze is there. And Courier-Bilson syndrome is the paroxysmal PTU by virtue of the use of the sodium valproate. And you can see the downward beat nystagmus in a patient who received valparin, and you can see the nystagmus appeared. And just after the stopping, the valparin, no nystagmus is there. So there are some occasional rare condition which can occur. Downward beat nystagmus found to be mostly occurring using the sodium channel blocking anti-epileptic drug you are seeing here. Now, this is again a very, if you, nowadays we are using Vigabatrin and all, but one thing which is very important, try to be, ask the patient to be in ophthalmologist supervision as well, to especially to check the bilateral visual field constriction, which is very, very known in cases of Vigabatrin. Topiramate, if it is started, always have a help from ophthalmological colleague as it can produce a narrow angle glaucoma. Other drugs like zonisamide, acetazolamide can have a topiramate. We know that acetazolamide we use in many cases, but definitely we should know and we should have a concern to pick it up and to refer to ophthalmologist as well. 13-year-old patient with on topiramate presented with severe abdominal pain, and we know that topiramate is important, which can induce nephrolithiasis. And these are the, you can see the stones in the kidney, and it was removed after. This was according to this article in the journal. Just to show you and to make you aware that if you are giving topiramate, try to be having the calculus screening as well. This is a patient on rufinamide. As you can see, the bradycardia is there and short QT interval. Again, if patient is on, try to monitor the ECG as well. Rufinamide, carbamazepine, and lamotrigine can have this. Valproate, we know that it should be cautiously used in cases of pregnancy and adolescent weight gain and amenorrhea and PCOD can be there in valproate. You can see the hirsutes. Another area, if you have given the patient on oxcarbamazepine, and we know that it is causing hyponatremia in patient. So, and this is the ECG before oxcarbamazepine, EEG in or during oxcarbamazepine. So there is a severe hyponatremia, hypochloremia can occur during the treatment with oxcarbamazepine, and therefore we have to take care of sodium level as well. So monitoring of sodium level before establishing oxcarbamazepine and during the therapy is again a practical tip using this drug. Now, these are the clinical tips which I have brought for you, which can be useful in your daily routine. The seizure story shapes the script. Know the type before you write. And it is very important that emphasize that seizure classification is the first step in appropriate anti-seizure medication selection. This is again an important tip. Second, in doubt, stay broad. When clear, stay sharp. That would mean that use broad spectrum anti-seizure medication if seizure type is unclear, and narrow spectrum when you are confident about the focal onset. This is again a practical tip. Syndromes unlocks the success. Don't just treat the seizure, treat the signature. This is again very, very important. Highlights the importance of identifying epilepsy syndrome and not just the seizure. When the genes speak, sodium must sleep. This is again a practical tip. This is relevant for SCN1 mutation, where we have discussed in lot that related syndrome, sodium channel blocker must be avoided. For example, in the Dravet syndrome and other the SCN1 spectrum, which we have seen. The best anti-seizure medication is not the newest; it is the one that fits the patient best. So never try to immediately start the newer anti-epileptic drug. It should fit with the patient best. So personalized medicine over trend-based choice. This is the very important message. Always start the monotherapy with meaning. Combine only when needed and with caution. So rational, evidence-based use of polytherapy is again very, very important. Stay with monotherapy, have confidence with monotherapy like that. In girls who may conceive, valproate must live. This is again a matter. We all know that the history of the present existing adolescent, and so we have to be very cautious before prescribing valproate in these girls. Reproductive risk-based guidance for adolescent girls and women of childbearing age. This is very important message. Etiology guides strategy. Structure, genes, or syndrome will shape your script. This is again etiological clarity, ensure more precise drug selection. So try to reach to the etiological clarity and therefore the precision medicine or focused medicine. Don't chase the seizure with blind bullets. Know your target. This is again a very clear-cut message. Don't chase the seizure with blind bullets. Avoid reflex prescribing without classifying the epilepsy seizure. Oh, seizure, not controlling, give this. Oh, immediately start with. So you have to be very clear. Avoid reflex prescribing. This is again important. Two failed drugs demand a deeper plan. Don't delay when the brain pays. This is again a reinforce early recommendation for early evaluation of the drug-resistant epilepsy. So these are the important tips which we should remember. So that and this is again a very important what Sir William Osler had said, and it is true for today only. Today also, the young physician starts life with 20 drugs for each disease, and the old physician ends life with one drug for 20 disease. So have confidence in your diagnosis, have confidence in your drug which you are using, so we can avoid not many things. So this is all about how this lecture was not a, see, epilepsy is a huge topic. You can speak for epilepsy for weeks also. So this is how I thought maybe as having some different touching the concepts. So the topic can easily be inculcated. Nobody teaches or guide you in 1 hour or 1.5 hour. Just a concept building in this important clinically relevant topic, which we all treat. I know I may be treating less, and you are all treating as you are in the metro area and having a huge OPD and huge college and good diagnostic facilities. Your experience may be much more than me. Definitely, your experience will also add in this the discussion in this group. So this was all about my presentations, and I don't know how I have justified my topic. I have tried that it should appeal to general pediatrician because it was a focused general pediatrician. It was not for neurologist or we all are general pediatrician and we are focused neurology and concept building was my aim. Over to Dr. Swapan and Dr. Kalpana.
Thank you.
Yes,
Thank you.
it's a wonderful lecture, sir. In your
Thank you.
lecture, there's a diversity in the lecture, but you have included everything: pathophysiology, the mechanism, the mutations, so genetic
Yeah.
aspects, and then the how to choose the drug interaction, and also you have touched very nicely the pharmacokinetics and pharmacodynamics, also the plasma half-life and the elimination time, because only by the elimination time and plasma half-life we should wait for the
Yes.
response. Otherwise, go
Mhm.
on changing the drug every
Mhm.
alternate day is not the treatment policy in epilepsy. It's a very, very wonderful lecture. I invite Dr. Chopin to say a few comments and then others to comment,
No,
please.
no,
If there are
madam,
any
there are a
questions,
lot
let
of
me know.
questions, I think. Aditya, can you post the questions? Aditya, can you post the questions?
So there are no questions, sir.
Okay, so this is the
Let's
first
read
time
this.
we got no question because Anoop bhai has taught so well that everything is clear. Now, it was a very transparent and clear-cut presentation, and it's very new with all your animations and all this. I can see three videos going in a single slide, so it is extraordinary. So I think Kalpana madam, you just give your final comment, and I must congratulate Anup sir.
Thank
Whenever I
you.
have
Thank
called
you.
him, he never said no. He never
Uh,
said no, be it in Howrah or West Bengal or any
yeah,
structure.
okay.
The thing is that
Thank you.
today all the students, PGTs, most of the PGTs has joined in the other audience link. They will be very much benefited. In fact, I am just thinking myself as a student, I'm glued to the screen. So I glued to the screen. So it was an
Thank you.
extraordinary presentation by
Thank you.
Dr. Anoop Verma sir. So
Thank
over
you.
to
Thank
you,
you.
Kalpana madam, for if you have got
Yes,
any
yes.
addition.
Yes. So, sir has done the 100% justification of 1 hour time with the whole epilepsy from the etiology to the management part. And it would be possible, only possible by Anubarma, sir. Because in 1 hour, we learn the pathophysiology, etiology, mutations, classifications, how to approach treatment, management, and of course, the some tips. And tips are wonderful, very practical and very catchy and remembered. So it's very a very good presentation. I
Thank
think
you.
anyone,
Thank
I
you, sir.
welcome Dr. Shikantoda if you want to say anyone. Dr. Mihir.
I must say that it's an excellent presentation on starting from basics, absolutely from
Yeah.
basics, and from undergraduate level to the postgraduate and teachers and to the experienced clinicians. Everyone will be benefited. That's very nice presentation, and as Kalpana has said, that is only possible by a person who is so experienced and has always gone to the root to explain the sign and symptoms and the response to treatment. So thank you, Anoop bhai, for the
Thank you.
excellent
Thank you.
presentation.
Thank you, sir. Thank you,
So
sir.
it's
Thank you.
now open. So Aditya, can you open everybody? If anybody wants to ask anything, Dr. Verma is ready. So Aditya, just
They can,
unmute
sir.
all.
They can.
So if you have got any question, anyone, you can ask Anoop bhai. I think they are really shocked and mesmerized.
Yes, they are all puzzled.
They are all
They are
puzzled
busy
and
in arranging the
mesmerized.
puzzles.
So uh,
Thank you, sir.
we are really grateful to you, Anoop bhai,
Thank
on
you. Thank
behalf
you.
of
Thank you.
West
Thank you, sir.
Bengal Academy of Pediatrics. I'm really grateful to you. And for giving the vote of thanks, I will request Dr. Mihir Sharkar, our secretary, to conclude the
I
session
can't
after
see him.
giving vote of thanks.
I
Mihir is
can't
not,
see Mihir. I can't see Mihir.
so if Mihir is not there,
Nilanjan is there. Oh.
Nilanjan, can you just give vote of thanks? Nilanjan. I think he is practicing with thing. Anyway, anyway,
No,
thank you
it's
so
all
much,
okay, sir. Thank you.
and thanks all the audience who have joined. And Dr. Apurva Ghosh has left because tomorrow we have got a program in ICH on cystic fibrosis, so he has left. So otherwise he could have given some comment. Again, thank you everybody, and thanks Dr. Verma for your
Thank you, sir.
excellent presentations.
Thank you
So
very much. Thank you, sir.
we
Thank
call
you
it
for
a
honor.
day.
Thank you
Thank
and
you.
good night, Anoop bhai.
Thank
Good
you.
night.
Thank you for the honor, sir. Thank you for the honor.
Thank you. Thank you.
Thank you, sir. Thank you all.
Thank you, sir.
And good night.